From Microbe TV, this is Infectious Disease Puscast, episode 38, recorded on September 27, 2023. I'm Daniel Griffin, and joining me today is Sarah Dong.
Hello, everyone. I'm Sarah Dong. Welcome to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. How are you doing today, Daniel?
I am doing well. I was a little worried. Our listeners, Sarah was 12 minutes late. And I am such a punctual person that David Renato, who helps us, produce these, he and I were quite worried about you.
I'm here. Yes, I do not like being late. So thank you for waiting. Well, we're excited to talk today. Puscast, if you guys know, of course, is a review of the ID literature for the last 2 weeks that we found interesting or entertaining. So on to the literature, shall we?
All right. Well, the first one in the viral section is actually a plug for a paper that I will be doing a very deep dive on in the TWIV clinical update. And the article, Distinguishing Features of Long COVID Identified Through Immune Profiling, was published in Nature. This came out as a preprint previously, but now it is published in Nature. This is by our friend Akiko up at Yale and a bunch of other folks as well, a collaboration with Mount Sinai. So we've got the two cohorts. And just as a teaser, I will tell you what Akiko says. Our key findings summarized by Akiko. Patient-reported outcomes alone are sufficient to identify long COVID patients with 94% accuracy. I think that's really important for people that are all worried that this is going to exclude people. So basically some validation. If it smells, if it sounds like long COVID, yeah, it probably is. Immunophenotyping reveals increases in exhausted T cells, IL-4, IL-6 double positive T cells, activated B cells, double negative B cells, and non-classical monocytes. Number 3, SARS-CoV-2 specific antibody responses were found to be elevated in long COVID patients after vaccination. So these really high levels. And this is important, just a little bit of number 4, evidence of herpes virus reactivation in long COVID patients. Now this is not herpes as in, it lasts forever and love doesn't. This is EBV and VZV, so herpes viridae. So let people know that. No increases in autoantibodies to the extracellular proteome in long COVID. So a little bit of a surprise, not really supporting that autoimmune approach theory. Machine learning shows that long COVID can be efficiently predicted from immunological data alone. And number 7, it's really interesting. Low cortisol levels were the strongest predictor for defining long COVID status and predicting disease severity. Why is that not in the title? All right, so deeper dive, come for that. And hot off the press, and I do mean hot off the press, inserted almost in the 12 minutes that Sarah was delayed. Severity of the influenza-associated hospitalizations by influenza virus type and subtype in the USA 2010 through 19. A repeated cross-sectional study was published in The Lancet Microbe. And here we learn that individuals with influenza A, H1N1, PDM09 had higher odds of in-hospital severe outcomes compared to those with influenza A, H3N2. So H1N1 worse than H3N2. Adjusted odd ratios for ICU admission, 1.42, 1.79 for mechanical ventilation or ECMO use, and 1.25 for deaths. So when people say, oh, COVID is just like the flu, maybe you should ask, which type of flu? The really bad one that kills you?
And I clearly look like I was going to add another viral article, and I must have not come back. So I will move us into the bacterial section. Don't forget to listen to This Week in Microbiology. I pulled a really quick article, which is probably going to be a little bit of a theme because I'm on service. So some of my reads were on the shorter side this week. But in CID, cefazolin for the treatment of CNS infections. So this actually was a response to the recent antibiotic myths paper, and we actually covered and sort of read through those in a prior Puscast. But specifically the myth that cefazolin should be avoided in CNS infections, and that sort of myth busting was suggesting that cefazolin is a reasonable option for CNS infections caused by susceptible pathogens. So the author here is just pointing out, what CNS infection is cefazolin appropriate for, and just trying to suggest that maybe we shouldn't be quite so fast for using cefazolin with meningitis, that even if cefazolin crosses the blood-brain barrier and has appropriate CSF concentrations, that treatment is not just related to penetration and pharmacokinetics, but sort of agree that the use of cefazolin or an anti-staph penicillin with spinal epidural abscess is something that they would feel comfortable with. I didn't bring this out to answer the question. I think the debate continues, and that there are some who would still remain cautious using nafcillin or oxacillin. But, the points about epidural abscess being different, I think is a lot of people are on board with that. I think the hardest problem is the long-term use of nafcillin or oxacillin once you have this patients in OPAT. And I get the sense that people may be further on, if they were nervous using cefazolin up front, may be able to use these sort of reviews of the literature to convince themselves to switch off of the anti-staph penicillin. But, we'll see. People can send me their complaints.
Well, I'm excited at ID Week. Maybe this will be something that people are, passionate to chat about because, obviously Alan Tunkel was not happy at the suggestion. And really, this paper is really Alan Tunkel's not happy with the idea that you should use cefazolin for meningitis. And I thought it was kind of circular. I have to say, Sarah, he's like, because there isn't a lot of experience or studies supporting its use. I'm like, well, that was the point because of the myth that nobody's using. Anyway, okay.
Yeah. I feel like it didn't really change anything. It was kind of a personal opinion, which I guess is what most of, these responses are. But I'll just throw it out there. That way people can debate amongst their group and tell us how it goes.
Yeah, we'll be in Boston if you want to come and yell at us. All right. The article, Rifampin-Based Therapy for Patients with Staphylococcus aureus Native Vertebral Osteomyelitis, a systematic review and meta-analysis was published in CID. So, for starters, this is a meta-analysis. Nothing new here, just a whole bunch of stuff piled high. The investigators searched the Cochrane, Embase, Medline, Scopus, and Web of Science databases for studies published up to May 2023, focusing on adults with NVO, native vertebral osteomyelitis, treated with or without rifampin-containing regimens. Ultimately, they settle on 13 studies, 2 RCTs, and 11 comparative cohort studies comprising 244 patients with Staph aureus, non-vertebral osteomyelitis, who received rifampin, and 435 who did not. Meta-analysis showed that rifampin-based regimens were associated with a lower risk of clinical failure. Only one study reported on adverse events. All the studies had, this is important, a high or uncertain risk of bias, and the certainty of evidence was rated as very low. So they have a really nice figure, too. And I always like, when I look at a meta-analysis, to look at a forest plot, and that's what figure 2 is, trying to look at the different studies. And basically what you can see is these lines overlapping all over the place. You can also see, how many events were in each of the different studies. They conclude, and I'm sort of glad, a prospective randomized trial is underway. So interesting, but not ready for primetime practice-changing results here.
The next one I pulled is, it's also from CID, State of the Management of Infections Caused by Multi-Drug-Resistant Gram-Negative Organisms. So this is another one of those really nice reviews, which I feel like I'm just going to highlight pretty much all of them. But it focuses on risk factors for multi-drug-resistant gram-negative infections, how to choose empiric and definitive treatment, and then some factors related to transitions of care. So I think just as a reminder, the most commonly cited risk factors would be antibiotic exposure in the last 30 days, and infection or colonization with an MDR gram-negative pathogen in the prior 6 months. I suspect that anyone who's on ID consults has discussed this with a colleague when they want to use a different antibiotic. There are other risk factors, of course, like comorbidities and devices and so on. But I think important to note that international travel can be a contributor, particularly if you're traveling somewhere else where certain beta-lactamases are more prevalent. So I'm not going to dive into selection of agents, but I think this is actually a really nice reference, particularly for learners on the team who may not be as familiar with using or approaching resistant gram-negative infections and sort of paired along with the IDSA guidance. I did just transition to a hospital where they use a BioFire pneumonia pathogen panel, which I was just going to say I'm not used to. And I thought about because in this paper, there's a figure 2, that provides a timeline and summary of the types of rapid diagnostic tests we have for pathogens for blood and respiratory samples. And so there's, a couple resources for pathogen identification, and some of those include detection of antibiotic resistance, which of course has some limitations that we won't talk about. But the last thing I kind of pulled out is they did point to the escalation antibiogram. And I actually couldn't remember, Daniel, if we talked about this paper. It had come out last year, but just an interesting concept to how people make empiric treatment adjustments in patients who aren't responding. So I put a link to that paper on the escalation antibiogram. But again, just a really nice summary, ties into a clinical vignette, really good for learners to hand out on your team.
All right, excellent. I mean, my takeaway is you only have to look 6 months back. So if someone's like, oh, they had an ESBL, I'm like, oh, that was 7 months ago. I'm sure that has no relevance. All right. Now, I do not know if our listeners are following the CDC and its plans to give us new categories of transmission-based precautions. But here's an article looking at contact precautions for MRSA. I don't know if you've been following that at all, but they're going to do away with the whole droplet airborne and give us 3 new categories for respiratory transmission. So I am very excited. But here we have the article, Are Contact Precautions Essential for the Prevention of Healthcare-Associated Methicillin-Resistant Staphylococcus aureus, recently published in CID. And I will mention right off, this is an opinion piece. So let me read the opinion. The recently updated SHIA IDSA APIC practice recommendations for MRSA prevention in acute care facilities list contact precautions for patients known to be infected or colonized with MRSA as an essential practice, meaning that it should be adopted in all acute care facilities. Now, we argue that existing evidence on benefits and harms associated with contact precautions do not justify this recommendation. There are no controlled trials that support broad use of contact precautions for MRSA prevention. Data from hospitals that have discontinued contact precautions for MRSA have found no impact on MRSA acquisition or infection. The burden and harms of contact precautions remain concerning, including the environmental impact of increased gown and glove use. We suggest that contact precautions be included among other additional approaches to MRSA prevention that can be implemented under specific circumstances. All right. Pretty strong opinions there.
I'm on board.
Well, it is clear that the institution of contact precautions has a negative impact on patient care. I remember.
Yeah. I mean, for MRSA, like this very specific point, I'm definitely on board. Yeah.
No, there's used to be like a chief of ID at one of the healthcare systems. He'll remain nameless. I think his only published article was he studied the impact of contact precautions and basically realized that when you institute contact precautions, no one goes in the room. Everyone kind of looks in the window and walks on by. So patients end up basically neglected in there. And so, it's one of those things, clear harm, and can we demonstrate benefit? All right. Anyway, all right. The article Impact of sequential implementation of a pharmacy-driven methicillin-resistant Staphylococcus aureus, MRSA, nasal swab ordering policy and vancomycin 72-hour restriction protocol and standardized antibiotic administration ratio, SAR, data for antibiotics used for resistant gram-positive infections was recently published in Infection Control and Hospital Epidemiology. Now, with a title that long, why didn't they just give us the result? These are the results of a single-center retrospective quasi-experimental study where they evaluated vancomycin use after the implementation of a pharmacy-driven MRSA nasal swab ordering protocol and a vancomycin 72-hour restriction protocol, and they found that this reduced vancomycin usage.
All right. And I will take us to our fungal section. I actually have another follow-up. This is from CID. Update on outbreak of fungal meningitis among U.S. residents who received epidural anesthesia at 2 clinics in Matamoros, Mexico. So we had previously talked about this outbreak when some of the CDC guidance and sort of health alerts were coming out. So fungal meningitis in patients receiving epidural anesthesia at 2 clinics. This was earlier in 2023. As an overview, 185 residents from 22 U.S. states were identified as at risk. Of those, there were 11 suspected, 10 probable, and 10 confirmed U.S. cases that were diagnosed. And there were severe vascular complications and 8 deaths occurring in the group. The causative agent was Fusarium solani species complex. There was antifungal susceptibility testing of one isolate that showed poor in vitro activity for most available antifungals. And currently, the recommendation was triple therapy with IV voriconazole, liposomal amphotericin B, and fosmanogepix recommended. There was a case noted in the article as sort of as an example case of a 30-year-old who had progressive nodular leptomeningeal enhancement despite multiple antimicrobials. And the patient actually eventually improved with compassionate use of fosmanogepix, which sounds like a really incredible drug. But it sounds like there's been a lot of struggles with what agents to use, and several patients, it sounds like, received intrathecal amphotericin B. So I think a big takeaway that was emphasized in the paper and for everyone to know is that many of the patients had neurovascular complications. So mycotic aneurysms, vasculitis, aneurysms, as well as intracranial hemorrhage and stroke. So just an update, and these cases sound really, really tough.
All right. Well, I don't know if people are aware of the case report, paratracheal abscess by plant fungus, Chondrosterium purpureum. First case report of human infection published in, I didn't even know this journal existed, but Medical Mycology Case Reports. We need to read that more. This is the case of a 61-year-old male patient from the eastern region of India who presented to the outpatient department with hoarseness of voice, cough, recurrent laryngitis, fatigue, difficulty swallowing, and anorexia for the last 3 months. No history of diabetes, no HIV, no renal or any chronic disease, no immunosuppressive drug intake or trauma. But, this is the patient, a plant mycologist by profession, was working with decaying material, mushrooms, and various plant fungi for a long time as part of his research activities.
Oh.
So that's a good bit of history. So with that in mind, a CT scan of the neck demonstrated the presence of a right paratracheal abscess. CT-guided aspiration of the abscess was performed, and pus was aspirated. Gram stain and acid-fast stain did not reveal anything. Fungal stain by Gomery's methanamine silver, GMS, that's what we all call it, showed septate hyphae. And they were able to culture this organism on a sabaroid dextrose agar and identified it by DNA sequencing. The infection was treated with complete drainage of the pus, followed by oral voriconazole for a total of 60 days. And are you ready for this? After 2 years of follow-up, the patient was absolutely fine, and there is no evidence of recurrence. And I wonder if he still works as a plant mycologist.
I searched what this looks like in real life. Hopefully other people will do it. It's very interesting.
It's beautiful, right?
Anyhow.
If you look at
it's actually quite
I would
pretty.
have hated to look in the back. I could picture from our previous, The Last of Us, looking in the back of the throat and seeing that image, and then
Interesting. It sounds quite prevalent. I guess it's on a lot of like plum, pear, like different types of trees.
I think,
anyway, sorry, that's the idea.
I think now that we're getting more of these advanced diagnostics, I think we're starting to see stuff that we didn't notice before. I had a patient just even today
I don't know what to do
who
with.
had these lesions in his lungs, and actually turned out to be some obscure tree fungus. So yeah, I think now that we're looking and have better technology, a lot of the stuff we may have just been missing, and a lot of people may have just gotten better on their own.
Yeah. Oh, so interesting. Okay, sorry guys, we'll get
It's okay.
We'll get on with it.
This is the crowd that cares. You're among friends here, Sarah.
Be sure to listen to This Week in Parasitism. Well, this next one was another like just really rare, uncommon case. It's from the journal Transfusion, Canadian Blood Services Traceback Investigation of a Suspected Case of Transfusion-Transmitted Malaria. So there was a 4-month-old infant who had been hospitalized since birth, who was found to have Plasmodium falciparum malaria in 2022. So the paper talks a little bit about this investigation. So the baby received 13 RBC transfusions, and then it sounds like multiple platelet transfusions. They actually went back to the donor, specifically those who gave RBCs, did a questionnaire, found the 3 donors who were deemed, quote, high risk, and they consented to being worked up, had P. falciparum serology and nucleic acid testing, and found 1 donor who was positive by serology and NAT. So a probable transfusion-transmitted malaria case that, in retrospect, probably had unrecognized symptoms, a semi-immune malaria infection, and, may have been infectious. Their look back didn't find any other cases of malaria transmission, but super interesting. And I can only imagine having a 4-month-old infant that you ultimately have the clinical suspicion to find malaria. I mean, that alone is impressive. And so this is sort of the backstory of looking into the transfusion. So interesting.
No, really interesting. All right. So the article, Strongyloides Infection Screening in Transplant Candidates. What is the best strategy? Recently published in Transplant Infectious Disease. So not just serology, but here they actually test feces and report that anti-strongyloides antibodies, immunoglobulin G, were detected in 19.3% and 20.7% of patients by immunofluorescent assay and ELISA, respectively. The strongyloides DNA was observed in 17.3% of samples by conventional PCR and 32.7% by a quantitative PCR reaction. So, I mean, usually I have to say what we do, we do a serology. If it's positive, we'll treat with some ivermectin. If it's negative, we'll treat with some ivermectin. So this is pretty exciting stuff here.
I'm glad you I had marked this to go back to and didn't get a chance to, so you saved me. And then I have one paper that I logged under miscellaneous because it didn't quite fit anything. But it's from JID, Thinking Small, Stinking Big, The World of Microbial Odors. So microbial odors are mediated by volatile organic compounds, as small organic molecules with low boiling points that are generally synthesized at some point during the microbe's metabolism, and which or what compounds mediate what odors and to what purpose is a topic of investigation. And they have some sort of fun wordplay. There's subheadings where we want to smell them, they want us smelling them. But they, briefly touched on the detection of infection by way of scent. And we've actually talked about this with like the odor sniffing dogs, but I didn't know this. There's some studies looking at African giant pouched rats and identifying TB and sputum samples. And I also didn't know anything about how Plasmodium falciparum has been found to produce detectable changes in human breath metabolites during infection, which the Anopheles mosquitoes can sense, which then makes the infected patients more attractive to mosquitoes and sort of enhances their own transmission. So I could have pulled a variety of quotes, but I figured why not read what they did as a conclusion. We float every day through a vast ocean of smells that we are only now learning to pick out of ambient air. Pathogens have clearly wasted no time in utilizing scent to bolster their own fitness. Now that we are aware of these microbial odors, which opportunities to leverage them for human health will bear fruit? Only the nose knows.
Oh my gosh. That is terrible.
So that brings us to the end of this podcast. As always, the references for the show are available at microbe.tv, the home of our multimedia empire.
You can find the Infectious Disease Puscast at Apple Podcasts, microbe.tv/Puscast. And we love to get your questions, comments, and paper suggestions. So send them to puscast@microbe.tv. If you like what we do, consider supporting the science shows of Microbe TV at www.microbe.tv/contribute or Parasites Without Borders at parasiteswithoutborders.com and click the donate button.
I'm Sarah Dong. You can find me on Twitter or X at swindong, at Febrile Podcast, or at febrilepodcast.com.
And I'm Daniel Griffin, and you can find me at CUIMC, Columbia University Irving Medical Center, or parasiteswithoutborders.com, as well as on the other podcasts, This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye.
Thanks for listening. We'll be back in 2 weeks. Another Puscast is infectious.